Okay, I think we'll make a start. So I think we'll make a few others, but I think we'll do a lot. But anyway, the idea is today to give an overview of Implant. My name is Dev Patel. I'm the program director here at Eastman. I've been here for quite a few years, 20 plus years. So I did my training here back in '97, finished in 2000. So we involved with the teaching program here in Implant Dentistry. We have a team of 8 specialists who hold our program. Most of the work is done on a part-time basis. So all our teachers are specialists, either orthodontists or oral surgery, and they usually work on a Tuesday or Wednesday. So most of the program is run on Tuesday or Wednesday. But let me give you an overview of the whole process of implant dentistry, so that you have that. So let's begin. Okay, so there's two aspects. So we've got people who are virtual online here. We've got a few people lined up here. So those people who are on virtual remotely, welcome on board to our taster session. I can't really see you guys because I don't think your cameras are on, but anyway, welcome on board. So the idea today is really give an overview of implant dentistry, look at training requirements, look at opportunities, and then a Q&A. And that's really for the next 1 hour for both people on site and also on remote. And then after, at 3 o'clock, we'll take you guys across upstairs and we can show you around, and we can do a bit hands-on, remind you what it's all about doing implants. And I said there's a reception, drinks afterwards from 4 o'clock in the cloisters over across at UCL, which we'll take across as well. Okay, so I'm not going to teach you guys the psychetics, but in terms of what an implant is, the key thing with an implant is basically the titanium screw. Often when a patient thinks about an implant, they think about the whole thing. We always talk about the titanium screw bit, but fundamentally you've got 3 aspects. One is the titanium screw that goes in, which is the implant. Then you have an abutment that connects the two, and then the crown that goes in top. Often nowadays we prefer to have screw retained restorations. So the abutment and the crown is one piece. So it's literally a 2-tier system: implant and then screw on crown, and everything we do is pretty much screw retained. And I mean, pretty much the treatment of choice nowadays to replace a missing tooth is a dental implant. Not always, but most of the time, provided that factors are favorable. So what's involved in terms of implants? So what we have to think about is patients. There's 5 aspects. The patient selection is number 1. With anything in dentistry, it's all about choosing the right patient. If you choose the right patient, your treatment will always work out well. If you choose the wrong patient, it doesn't matter how good you are as a dentist, you're always going to get your fingers burnt. So choose the right patient is the first aspect. Then you look at planning. Then we look at surgery. Then we look at restoration. Then we look at maintenance. Now, if you see at these 5 points, there's one thing only on surgery. Okay, most people think that implant dentistry is all about surgery. And they always think, oh, I need to go and do some more surgery to learn how to do implants. But surgical aspects of implants are only 20%. 80% of implant dentistry is actually restoratively based. So as a general dentist or a specialist, really it's the restorative aspects that you need to be more focused on. That's why most of our teachers are orthodontists, because that's really where most of the planning, restoration, maintenance occurs. The surgical aspect is only 20%. The skill set to be able to do implants, so it gives you a guide, is that if you can raise a flap and remove a tooth surgically and close it with some sutures, that is the skill set you need to have. If you can do that, you can do implants. If you want to do advanced bone grafting and stuff, then the skill set is to be able to take out an impacted wisdom tooth. So if you can raise a flap, remove bone, section a tooth, remove the impacted wisdom tooth and close it off with some, sutures, that's the surgical skill set to be able to do advanced grafting. Okay, so we don't expect you to learn to do more advanced stuff. Our objective really is to be able to, for you to do straightforward cases from start to finish. And we're very much a believer whoever places should restore, and whoever restores should also place, because you are the best person. And often we have a lot of controversy with patients that say, oh, well, someone else did the surgery and someone else restored it. Who's responsible? Who takes charge? And it's better if you just do the whole thing and look after that patient as a whole. So our training is geared on that basis. So if we break it down a little bit, so patient selection, things that we need to look out for, I mean, history examination, special tests are standard stuff, what we do day in, day out. But yeah, you've got this patient here who's got, dark and gum rot, lots of perio issues, chronic perio problems. The danger we have this day and age is that, they could go to one of these all-on-4 clinics, teeth come out, 4 implants, make a bridge, and the patient's delighted. However, what will happen in a year's time? For a patient like this, if you do that for a patient like this, it's going to come out with plaque everywhere, peri-implantitis, failing implant, it'll be a complete disaster. So we have to go back to basics. And someone like this, really, it's not that I'm saying no to implants for him. I'm saying that we need to stage it. So we need to get disease control. So we need to say to the patient that, look, what we need to do is, first of all, introduce him to a toothbrush and teach him how to bloody brush his teeth. That's the first step. The second step is look at, stabilizing disease, like maybe keep a couple of these teeth, like the canines, maybe the first molars, get rid of everything else, give them a partial denture that we can reestablish his occlusion, his tooth positions, his appearance, and so we can reestablish everything that's required so we know what the end point is. And then if his maintenance is improved, everything becomes healthy, then we can then think about potential implants. If it doesn't improve it, then we have to then say, look, you have to really stick with the denture work and probably end up being complete dentures, or we might be able to give them maybe an implant over denture possibly. So options are there, but it's good to do it stage by stage, and it's all about disease control. So it's very, very important to choosing the right patient. A lot of it is down to diagnosis, what's caused the loss. So if it's through periodontal disease, the bone loss that causes the disease that causes bone loss around a tooth, that same disease can cause bone loss around an implant. The patient who loses teeth through periodontal disease is a high-risk patient. So what we try to do is categorize patients into high-risk, low-risk. The patient who's lost a tooth because there's a failed root canal or a failed post-crown, they're a low risk. Because the reason why they've got root canal is because they've got caries and it's got a large cavity and it's mechanically broken, right? So chance of an implant failing because of caries is non-existent. It's great. You can eat your full arch implants. You can have as much sugar as you like, no problems. You're going to get caries, but perio we will have. So patients who lose teeth because of endodontic failures is actually a low-risk patient. So we have to categorize them in terms of risk factors. And it's only once you've got a diagnosis and you work out a plan and we can discuss options, then we work out a treatment sequence for them. And invariably, there is a sequence, and a patient needs to understand that this is not a quick fix, teeth in a day, you're going to get your teeth. It's a whole process. So we've got to plan the case, we need to make a surgical guide, we need to guide the surgery, we need to place the implant, we need to allow the implant to integrate, we have to then uncover the implant potentially, may have to consider grafting of some form, potentially, you need to think about a provisional restoration and then a definitive. And I always say you need to plan the best part of 9 to 12 months to complete treatment. Yeah, I mean, best case, you might be 3 or 4 months if it's a straightforward non-aesthetic case, but there is a range, it's not a quick fix. But we need time for implant to integrate. There are obviously things like immediate implants we can do and stuff, but again, that still needs time for it to integrate, make sure it's stabilized before you make definitives. So we have to give that opportunity. If you see on this OPG DPT, you can see this is a classic example where it's all kind of gone wrong because the planning's so poor. So you can see that patient's got multiple crowns, they're all linked, got periodontal diseases, bone loss down to the furcation, periendo lesions, the whole thing is collapsing and failing, and yet he's had a full-blown sinus graft, entire sinus is blocked off, and a single implant. I mean, what benefit is that treatment on that one side when everything else is failing? So we have to be quite holistic in the approach. So even though they may come to you, say, oh, actually, I've got these teeth missing, I want to fill these, you need to have a look at the bigger picture. And our objective always to give the patient, trying to keep what they've got first before looking at replacing what they're missing. That is the objective, because otherwise they're going to come back to say, why did you do all this work on one side when everything else is failing? And you just get it from this person. So always treat the patient as you've been taught at undergrad school. And I said diagnosis is key. So things that we need to be aware of is risk factors. Kind of alluded to the fact that periodontal disease is a major risk factor. and we don't know how well that will fare. So it's important to get the patient stable from disease on the periodontal level before you commit to implants. Obviously, smoking is a big risk factor. I always say things like patient expectation is also a risk factor, because if the expectations are so high, can we meet it? And this is one of the challenges we have with things like AI and smile design. You have these beautiful smiles that AI has generated, but can we deliver it? And so you have to be quite mindful that, because patient will then see that, and you sent that to the patient, sent a video of this beautiful smile design. Now you've got to produce it. And if you don't, they'll say, well, actually, look, this is what I brought into, and this is what you've given me. We have a big problem. So we have to be realistic about what we can or cannot achieve. And I often say to the patient that, and the problem we have with the patients is that, they come along, and the rule is that, if they can afford an implant, they can afford a barrister. Right now, I'm not a big believer in defensive dentistry. I'm a big believer in doing the right thing for the patient. And if you do the right thing for the patient, you have no problems. But we have to just be realistic of what we are going to do and what we're not doing. And the most powerful thing is to say no to a patient. I often say to the patient, I'm not good enough. You need to find someone better than me. If the expectation is so high that you don't think you need it. So just be mindful of that side of things. Things like space is important. Space analysis, you need to have enough space. So even if you've got a tooth missing, if you don't have enough space, you can't restore it. So we have to maintain biological width and biological space to be able to restore restoration. And often when you have a tooth missing, you may get some drifting, tilting of teeth, which limits how much space you have. You may get overruption of the opposing tooth, which limits the interocclusal space. So we need to make sure we have enough space to work with to be restored. If you don't, then the implant's not the option. And often you may have the space for the implant, but not the restorative space for the restoration. So we have to then always think about your diagnostic workups to make sure we can meet the requirements. And the final thing is bone. You need to have enough bone to have an implant. And the normal height of bone you need is between 8 to 10 millimeters. Width-wise, you need about 6 millimeters of width, so you've got at least a millimeter of bone either side. That's a minimum. The more bone, the better it is. If you don't have enough bone, we can always build the bone up. Lots of great techniques, guided bone regeneration, particularly building width up is very predictable. Building height up becomes more challenging. But if you've got patient's natural bone, that's a no-brainer. And that all comes back to things like socket management and extractions and atrial extractions, because if you do that well, then the need for grafting becomes very minimal. If you do the extraction and everything poorly, then you lose all the bone, and then you have to then think about doing more grafting. So a lot of it comes down to pre-implant planning as well. So coming to planning. So implant planning. So our objective really is to place an implant so it's exactly below where the planned tooth position is. Okay, and so we have screw access. So we don't always have straight line access like this, but the objective is to have screw access here. So it's really important to get the implant exactly how it is. Now, the only way to really work on that is really, you've got to do a diagnostic wax up to determine where the final tooth is going to be. If you know where the final tooth size, shape, and form is, then we can then place an implant immediately underneath it. What happened in the older days is there's oral surgery used to place an implant where the gap is and where the bone is. No idea where the tooth is, and then we as restoratives had to then try and create something to restore it, and it was very difficult. That was a mess. So now it's very much restorative driven. We call it crown down planning or restorative driven implant placement, because we want it exactly where it should be. And if you can't place it exactly where it should be, then what are our options? Do we need to position the implant slightly in a different angle? Do we have to use angle screw channels? Do we need to build the bone up? And there are various ways of doing it. And then we do a lot of, it's all digital now, it's all digital planning. So we use software packages. So a patient gets a scan with an STL, we have a CT scan with DICOM, we merge them into a software package, and we plan the whole thing on a software, one of the softwares, implant planning software. There's several out there. Based on that, we'll then make a surgical guide, which is for guided surgery, with exactly where the implant should go. And then you can just drill a hole through there and you can place an implant. I can make you one of those today, and you can do it in your practice tomorrow, and you get the implant exactly where it should be. So the learning comes of where do you place it, how do you place it, what are the factors, and that is key. the actual practical procedure is actually not that difficult anymore. They've simplified the whole thing, and with technology and digital planning, it has made life a lot easier. Yes. Yes. So you need to have everything digital. So you need to have, the CT scan, which gives you the DICOM images, the 3D images that you need on the software package to tell you where the bone is. Then you do the STL of the patient's mouth that you can, oh, it don't have to be an STL. I mean, you can always take an impression and scan that study cast and transfer that across. So if you have like an iTero or a 3Shape and scanner, then you can scan that and bring that across. And then you can merge the two together, and then you can then do the plan.
You need to have access to VBCT for the board.
Ideally, for patients, I mean, we have a scanner here. So if you can, I mean, so for the course itself, in the year 2 program is when you start doing surgery and patients treatment. So they usually come here for assessment, and we'll do the CT scan here on site. So you don't really would need one per se. But if you're going to do things in practice, it might be wise to have someone where you can refer to and get a CT scan. Don't just have it in. And so once you've done a plan, you make a surgical guide, 3D printed, and then you can then place the implant. So the key thing really is you've got to work backwards. So you've got to work out where the final tooth is, and then work backwards to where the implant should go. And that really is the key. And if you can follow that basic concept, you can't go wrong. Really, I mean, it's very straightforward. So let me just show you a video of one of our students doing an implant case. So let me see if I can get that open, working. There we go. So that's a conventional route. So it's a bit like endodontics. When people do their master's program in endo, they already get really upset that they don't get taught rotary, because they have to use hand files. But what you have to think about is that if you're going to do rotary, if the thing breaks, what do you have to do? You have to go back to hand files. So if you don't have the skill set of doing hand files, then you are going to de-skill yourself. So with implants, similarly, guided surgery is amazing. It works really well. But occasionally when it doesn't go to plan, you have got to go back to basics. And if you don't know those basics, then you're going to be really stuck. So we will teach you from the basics. So that's why we would always recommend to go from the analog way of placing implants, so you understand that, and digital. So we cover both. So it's really important. But most of the stuff is done digital, but you do need to know the analog side of things. So we will teach both. So this is a digital one. So this is where you can see low right, low left 5 implant is planned digitally on a software package. You see the curved root of the 4, so it's quite close. There's a risk that it could actually devitalize that tooth or even get close to the metal frame. And so it's planned in a way that we're as far away as possible. Once we've planned this, we have a surgical guide that tells exactly where that implant goes. And that's what this is. Okay, that's the surgical guide in place on the tooth, and we're drilling through it. And then that's what's done. And I think that's the next one. And that's the implant placed. So it's exactly where it's planned. That's where the implant goes. So very well controlled. So it takes out a lot of the human error or iatrogenic factors that used to cause implants to be placed in the wrong place or wrong position. So digital implant surgery is really very powerful. And we would aim to use it in every case, even if it's just for one aspect of it. You could do it as just a drilling of your first drill only, or up to actually the full placement of the implant. There's a whole range. So depending on each scenario. This is another case. So a patient of mine who had 2 laterals missing. And you can see that if you look at the plan position of the tooth here and where the implant is, and you can see that we want screw access come out here. So it has to usually be 2 millimeters palatal to the inside of the ledge. You can see that's 2 mils inside, and same on this side. If you did it using where the bone is and just placed it without the guide or the tooth position, then you'll end up placing the implant a little bit more buccal. So you won't have screw access. That red line dictates where the exact maximum volume of bone is. So that will not work well for screw retainer restoration. That will be then cement retainer, which is what we're trying to avoid. Cement restoration is a complete nightmare. And similarly here. So having that subtle change from there to there is really important. And having that positional placement of the implant in that position is very important. So having that by hand-eye coordination is a challenge. Using surgical guides is really the way forward. So you see this is all done digitally with a surgical guide. And this is one of our first cases we did post-COVID. Had to be all under rubber dam and using all these hats and stuff. You remember those days? Complete nightmare. I can't believe that was 4 years ago. Crazy, isn't it? But yeah, my first implant case under rubber dam. It was bizarre. But anyway, it all worked out well. Bit of fun and games. And he got to single implant crowns. That's the day of fit. Shades just a little bit grey, but you know, he's happy with the end result of it. So how do you get involved? So implant, I mean, I've covered a lot in a very short period of time. So it's a quick overview. But you know, first of all, really is start identifying patients that are suitable for implants. Yeah, in your everyday practice, there must be patients who need an implant of some nature. So identifying those patients is the first step, and also identifying whether you think it's a low risk or high risk patient is quite useful. And that's something we'll teach you as well in our program, because the low risk ones are the ones that you should be doing. The high risk ones you should probably think about referring out. And then second thing is that the ones you refer out, don't observe it. Yeah. If you're lucky enough to have someone who comes in your practice and does a visiting set, go and visit and watch them do the work. Ask them to teach you and show you what they do, so you get an idea what's involved. And then after that is then thinking about doing some sort of formal training. So some of you already said that you tend to restore implants already, which is great. I don't know many courses that just teach you restorative on a formal basis. Usually it's like a local company, implant companies taught you, or your friend surgeons taught you something. But there's not a lot to it, to be honest. But there is quite a lot of fundamentals that you should be aware of in terms of restoration of implants, particularly things like screw mechanics is important, troubleshooting, maintenance, occlusion are these things that you really need to have a better understanding of. So we run our program is the first year of our program is the PG certificate program, which will cover patient selection, planning, and restoring. So it gives you the foundation. So if your interest is purely restorative and not surgery, then our PG certificate is really a good program for you. And I've created it for that reason. Because a lot of people said, oh, Dev, can we just do a restorative program? Well, it's not as simple as just doing a restorative. You have to have the whole package to a certain extent. But particularly if you've got a surgeon who does surgery for you, then you can then select the patient, plan the case with the surgeon, they can place it, and then you can restore it and then maintain it. And that's what the purpose of the PG certificate is. If you want to progress, then really placing implants, you need to do something a little bit more, which is a diploma program. The guidelines of what training you need to have is very willing, really down to the interpretation of what the GDC say, which I will explain in a sec. And the final thing is that even if you decide not to do anything related to implants, you still need to know how to maintain them. Because if you decide to do 0 implants, your patient will still turn up with an implant restored by someone else, and you will need to then know how to maintain it. So it's important for you to understand how that whole process works. So in terms of training, especially in the UK, the training requirements is all set out by the GDC. So the GDC have a page on training, and it links to the FGDP training standards, the Faculty of General Dental Practitioners, which no longer exists, and that is called college. And that training standard basically breaks down implant training into simple and complex. So there's 2 aspects, replacement of missing dentition involving straightforward cases, and then replacement of missing teeth involving complex. So the idea is that, any dentist can do implants. And if you're a general dental practitioner, then you should be doing the straightforward cases. If you're a specialist, then maybe you should be doing the complex cases. And it's the same as endo. Endo is a good analogy, okay? So everyone can do endo in practice. But we also have specialist endodontists who does the more complex. And implants should be exactly the same. The only difference is that we're not taught implants as an undergrad, whereas we are taught endo as an undergrad. So you need to then just develop a skill set in learning implants as opposed to that thing. And the requirements for straightforward, and that's what we're really focusing on, is, before undertaking implant treatment, a dentist must develop competence in the procedures involved in clinical assessment, planning, placement, and restoration. It's a whole process. And that whole process cannot be done on a weekend. So going off to some random country and banging a whole load of implants is not ideal training. If you're up against the GDC and say, what's your training standard? What's your training level? What have you done to learn about these things? And you say you've been on a weekend course, it's not really enough. Whereas if you said you've been on a 1-year program of some nature, which got some accreditation on it, then you'll be in a much stronger position. So just cover yourself. So what type of training and where? I mean, obviously I'm going to be a bit biased with our Eastman courses, but we do have quite a few short courses, which we used to run pre-COVID, but we're going to look at reintroducing those in the next academic year. So for those people who've already done programs somewhere else and don't want to be involved in a full training program, we do have like digital implant planning session of 2 to 3 days, implant restorative course, which is another 2 to 3 days, implant overdentures, immediate loading. So these are straightforward and advanced level stuff. If you do our main program, that's all included. I mean, the advanced courses only once you learn straightforward cases. I would not recommend any advanced courses unless you know the straightforward stuff well. And ideally, you want to do at least 50 cases before you start doing the advanced stuff. Learn to walk before you run. So formal accredited programs, we have 3. So we have a PG certificate in implant dentistry, which is the 1-year program. I think it's probably the only one that's in the UK. Then we have diploma in implants. So that's the first one is 1 year. The diploma is 2 years, which is basically the first year of the PG Cert and the second year, which is the diploma. And then the MSc is the number 3. So it's a 3-year program. So year 1 PG Cert, year 2 diploma, year 3 MSc. That's the way it goes. The format of the PG certificate, okay, it's really, I said, aimed to be able to teach you how to plan and restore cases, patient selection. And it's done on a blended learning program. So what blended learning means that we have 4 blocks of teaching on site here. So you would have to be here for like 2 to 3 days in October, December, February, and then April, something like that. So 4 blocks of teaching. The rest of it's done remotely, right? So you can be in Dublin and wherever you want to be, whether it be or Eastman, and not have to come up here. So the idea is that it's blended so that you get an idea of learning the foundation of implants and restoration. If you are local and on site, you're more than welcome to come on site because we'll make it all hybrid. So that, and so we've gone through our second cohort of students, and a lot of them said, well, actually, rather than remotely, can I just come in? And we are here and we run it like this. So those who want to be on site, they can. Those who want to do it remote, they can do it remote. But it's done fortnightly, so every other week. So your commitment is every other Tuesday for a year, pretty much. And then at the end of it, I said you'll be able to at least identify patients, plan cases, and restore. I mean, you'll actually learn a lot more than that because we do cover surgical side of things because we want to prepare you guys ready for those who want to move on to diploma. Okay. So it's a progression. So at the end of that 1 year, if you decide this is enough, you can then stop and then you get the PG certificate and then you can carry on practice. If you decide that you want to progress and think, actually, I want to place implants, then you can then progress to the second year. The second year is where you then look at placing, it's all surgical related. So you have progression if you want to. The only thing is that if you are UK based, GDC registered, then you can progress. And the way you need to do is you need to apply for the MSc from the outset. And at every entry point, you can then exit whenever you want. What that allows you to do is allows you to progress. If you don't apply for the MSc from the outset, you can't progress. So there's only 2 entry points. One is the PG certificate, which is for overseas dentists from abroad, but that's why it's blended learning. But if you enter from that point, you can't progress. So any UK dentists who are GDC based, I would recommend to go start with the MSc and then decide if you want to exit out and enter the applications. Okay, so the PG certificate is ideally UK and overseas students interested in developing their knowledge. We do have this thing called recognition of prior learning. So if anyone's done a program in the last 3 years, like a 1-year program or of any significant nature, there is an opportunity to use that as credits towards the program. But you need to apply for it from the outset if that's of interest. A lot of people do say to me, Deb, I've done this course, but really I want to come and do it at Eastman and get a university qualification out of it. What can I do? So that's why we've allocated this recognition of prior learning if it's applicable. But if you want more information, just give us an email. Costs for this year is for home students is 11,350 and overseas is 1,500. Be mindful that UCL always increase their annual fees by 5%. So unfortunately, every year it goes up. If you decide at the end of that year you want to progress to surgical aspects, then that's what the diploma is. Okay, so you'll then progress to year 2, which is the PG diploma. Now this is quite intensive. Literally, you've got to attend it every week, so every Tuesday, and that's where you will see patients. So you'll bring your patients. Unfortunately, we can't provide patients. I've been trying to organize patients forever, it just doesn't work. So the best thing is your own patients, and you can bring 2 of your own patients to be treated from start to finish, and we'll plan the case together, and then you'll place and restore that case with us under our guidance on a one-on-one supervision. And that's why it's quite intense because we've got to get it all done in a year. So what we do, we tend to start the year 2 program in the summer. So like our year 1 guys just finished last month, and they've just started the year 2 program last week. Yeah. What we want to do is start assessing the patients and then placing implants in September, October, so they've got time for integration so that they're ready to restore by spring, ready to submit for June exams. And the best thing, you only have to present one case for your exam. Okay, so back in the day, when we first introduced the MSc back in 2007, you had to present 8 cases, 4 simple, 4 advanced. Then I changed it to 4 only. And then we think, okay, well, with extended examiners, we used to wait a discussion why we're assessing 4 cases. Yeah, if you can show 1 case well, surely that's sufficient. The UCL thinks that we over-assess completely. So just you should show 1 case, very comprehensive case. But that's what we get to do 2, and out of those 2, you choose the best one. So the assessments are actually not too bad. It's quite intense because it's on site. There's no remote. Okay, for year 2, it's all on site here. Most of it's all clinic led. We do have lecture programs as well. There's also a possibility that we can offer mentoring in your practice or in the mentor's practice. So we'll allocate one of our tutors so that you could potentially do 2 additional cases under our guidance, either in our practice or one of the mentors' practice. It's a scheme called Implant Training Centers. So we're working on that to see if that can actually still materialize. But that's another option. Who should apply? I mean, really, it can only be UK GDC registered because you'll be treating patients on site here. So if you don't have UK registration with GDC, you can't treat patients. That's why it's limited only for those, because we want you to actually treat patients. We don't want it to be a theory-based program. It has to be hands-on, so we can actually teach you how to do it. If you finish that program, then you can move on to year 3. Okay, now year 3 is the MSc. Now the difference between an MSc and a diploma is a dissertation, research only, no other additional difference. And so you should only really think about doing the MSc if you have an interest in academia or you want to do a research project of interest. And so, and that is really almost predominantly remote done because it's pretty much research in your own, and you always meet up on a regular basis once a month to discuss what you've been getting up to. The only requirement is that you need to get a continuation requirement of a distinction in your diploma to be able to progress to the MSc. So really, those people are really interested in doing academia will have that option. But it's there. And our first cohort are going through as we speak. They presented this morning some amazing research projects, really useful. So great if you have an interest in academia. So we have the full MSc program now. So just to clarify, okay, our program is a 3-year part-time blended program. Year 1, you get a certificate. Year 2, you get diploma. Year 3, you have MSc. That's the whole process. It's a flexible training pathway, so you can exit at any point. If you decide after the first year it's not for you, then you get a PG certificate out of it. If you want to go all the way, you can. So you have a choice. All our teaching faculty are specialists in their fields, very experienced in implants and prods and surgery. So you'll have a one-on-one mentoring with them. We also have a lot of people who we invite from overseas and international and local here who will help support the program. So it's quite a robust program, ongoing for many years. We cover a lot. So when I say a lot, you know, patient assessment, occlusion, planning. We also teach you how to take photos and videos because you need to know how to do that well to be able to present. So if you already know that, you're ahead of the game. Wise to maybe learn that and develop that this day and age. The theory of implant science is covered. Digital planning is covered. I mean, that's a whole digital planning and learning CT scans and software packages is another learning curve. But we'll start that in year 1. So you'll know that in year 1 as part of the planning process. So you're all set for year 2. Other things like implant aesthetics, guided surgery, immediate loading, grafting, hard and soft tissue grafting is all covered as part of the program. And then obviously the prosthodontic side of things, troubleshooting, complications, failures, all evidence-based stuff as well. So quite a lot to cover throughout our period, and it's quite a short period, relatively. It sounds a long time, but it's not. It flies by in no time. most of our stuff is all hands-on didactic teaching. So we tend to break it up into morning sessions of teaching, afternoon sessions of hands-on, so that you balance it all out. We're trying not to do too much all-day teaching. Unfortunately, remote stuff has to be. Then when you're here, we tend to do it more workshop-based as well. You've got the ability to treat patients under supervision on a one-on-one on-site here, so you don't have to worry about anything. Everything's here laid out for you. You just turn up with the patient and we'll do the rest. There has to be assessments as part of a UCL training program. We have to do assessments. I'm a part-time practitioner as well in practice, so I know the challenges of working in practice and also the challenges of taking an assessment after BDS. Most people have not done an exam since BDS days, so the anxiety of something like that is always a challenge. So we try to keep it simple and as practical as possible. So your assessments are pretty much MSA, so multiple short answers or MCQs. There's no essays to write in your exams. We do get you to do essays as part of the ongoing termly projects, but they're not your actual exam mark grades. Therefore, continuing assessment. But you will have a practical test. Okay, so you will need to show us that you can place an implant and use the kit and place it in the right place. And you need to show us that you can make a restoration, a temporary restoration on top. But you have loads of chances to do that. We'll teach you how to do it. We'll do workshops, we do it on patients, and then you do the exam. So you will learn and develop yourself. As I say, when you have to have one case to present comprehensively for the main exam. And they said you could choose whichever case. You could do a case from your own practice if you want. Doesn't matter. It doesn't have to be the one here. So you can choose whichever case that is. So application process, as mentioned earlier, so postgraduate certificate is really for non-UK dentists. So that's what you need to apply for when because there's two portals you can apply for, PG certificate or MSc. Anyone UK based really should be the MSc pathway. And you could exit at any point. That's why you should do that. So they're the two main pathways for applications. What we're looking for in our students, I mean, we start with zero knowledge. Okay, so no matter what experience you have, we always start with zero knowledge because there's always someone who doesn't really know much about it. So we start with zero knowledge and develop it. And so, the level of experience you have, it doesn't have to be significant. To say minimum 1 year postgrad. Ideally, I would say that the more years you've experienced, the better it is. Not because about implant experience, but it's actually about restorative experience. If you've been in a practice for 3-5 years and you've done a fair amount of work, crowns, bridges, dentures and stuff, and learning the basic principles of restorative or in surgery, you're always set ahead. Whereas if you're doing the first crown prep or your first, face bow or your first, surgical extraction with us here, your learning is going to be much slower. Whereas if you've already done those bits, then you've taken it to a higher level. So having a bit of experience on your belt is much more preferable for your own development. We try to have a mix of people, when we choose our student numbers. And we usually have up to 12, 16 students in a cohort and working groups. Surgical experience is useful. I said, if you can learn how to, so the surgical skill set you need to have, as I mentioned at the beginning for you guys, is that you need to be able to take a tooth out surgically by just raising a flap, removing a tooth and closing it. If you can do that, you can place straightforward implants. If you want to do grafting and more complex, you need to be able to take a tooth out like a wisdom tooth, impacted wisdom tooth. So raise a flap, remove bone, section the tooth, and close it up. If you can do that, you can do advanced grafting. So if you have those two skill sets, whichever your preference is, you want to keep it simple, just a straightforward is enough. If you don't have that skill set, you need to go and try and find that skill set. I always say to the youngsters, how do I go and do that? So if they can go to a hospital post, that'd be great. A lot of people have already missed that boat, as it were. So just go and knock on the local oral surgery department and say, look, can I come and observe what you do, because I want to develop my oral surgery skills. And just say observe first, so you get your foot in the door, and then after a few months, you say, actually, do you mind if I do some surgery? Do some treatments on patients at no cost. It's investment. Yeah. And how are they going to say no? I mean, they're desperate for patients and people working. So That's a good way to get in. So try out, ask the question, and you never know. Or go on a program or something. That's the best way. If you've done some postgrad in the past, that's always helpful because that means you can take exams. CRDPs are certificate in restorative dental practice. So there is Eastman run lots of different programs. So there's a restorative dental practice program, which is restorative only. So the first is the certificate. So if you've done that certificate, you can pretty much guarantee you get a place because they cover a lot of the foundation that we cover as well. So it really sets you up really well. And if you are thinking about some sort of restorative program, I highly recommend that, at least for the first year. And then after that first year, you come and do other. They all get upset when I say that. You can't jump ship halfway through. But it's a good way to get some foundation in your belt. And also, we want someone who's keen and motivated to learn and also time to study. I mean, if you're going to come on board when, you've just bought a practice, you are going to struggle, aren't you? Because, your mind is all on the practice and how you're going to get it run and staffing and this and that. And we've seen it so many times. And then so basically the study becomes a backseat. And that's a waste of time and money for you, really, more than anyone else. So, it's a big investment. So make sure you've got time to make the best out of it. And the earlier you do it, the better it is, because then it's on your belt and you can then repeat it. Okay, benefits standing at Eastman. So we're quite lucky, and we do have quite a few industry people who come and support us. So Nobel Biocare is our preferred provider of implants, and they kindly do sponsor some free implants for you. They also sponsor things like Christmas dinners and graduation dinners, and give you good offers for startups if you don't have implant system already. If you already have an implant system in your practice, then stick with it. We teach on a generic basis, so you can then apply it to whatever system you have. We also use Geistlich for our biomaterials, and they often give us some freebies for you to try out. Also, as a UCL student, you'll have full access to all UCL resources. So if you can imagine, what does UCL teach? It teaches everything, law, architecture, you name it, physics, chemistry, whatever you want. So if you want to tap into the resource they have, you can do everything. You can learn how to make websites and do programming if you want. They have lots of online training programs if you want to do anything beyond dentistry. And it's very powerful. You have access to all the online training and electronic libraries, so all the journals and stuff, all electronic, and everything is there. So you can spend hours. And they also, the ebook library is actually increasing, so that's also available. It's all electronic. Gone are the days where we had to photocopy every paper and have a stack of them. It's all online. So we've moved here. So back in the day, we used to be at Grazing Road, pre-COVID days. And that is the original Eastman Hospital and where our training center used to be. But that's all shut down and we're completely here. And our institute is on the top 2 floors of this building. So on the 4th and 3rd and 4th floors is where all the training is. And then your lectures could be anywhere in UCL. I apologize in advance, it could be literally anywhere in UCL. UCL is a big place. So sometimes you might have a lecture that could be in Tottenham Road, another one could be at the other end of Russell Square. So it does vary depending on the availability. But it is great because you're part of the university campus and right opposite the main UCL site. So it's a great facility. Okay, that's pretty much the most things. Do you guys have any questions?
A question about the describing certain aspects. You think it's straightforward symptoms, and then there's the more complex.
Yes.
Later. Is that something you learn in that second year when you cover all of that, or is it just straightforward?
Straightforward only.
Straightforward only.
So the objective is to get you to be able to do implants on a straightforward level at the end of the program. So once you've done that, then we suggest you've got to do at least probably about 50 implant cases to just develop and cement that under your belt. And then you can then look at doing more advanced stuff. So that's why we have advanced short programs of 3-4 days where we can teach you sinus grafting, meter loading. But I would not recommend you start doing that unless you can get the basics right.
Yeah.
So it's just slowly developing it. And if you have a mentor or someone who can then guide you through the whole process, that really is key. Any other questions? Any questions from remote people? Any questions? So this is the last taster session for this academic year. The deadline for applications is in a week, I think, or something the next week, I think. So if you're interested in applying for the program for this academic year, which starts in October, you need to submit your applications, I think, by next week. Otherwise, you'll have to wait till the year after. So we'll organize more taster sessions from 2025 for the next academic year. Otherwise, I think if there's no other questions, I'm going to close and sign off. So thank you very much for attending, those people online, and thank you guys also for attending today and listening to our presentation. Thank you.